Good evening, everyone. I'm Dr. Indru Narayanan. I'm presenting the paper Management and Outcome of Congenital Microphthalmos and Enophthalmos in a Tertiary Center. Concern was taken from the parents to obtain to display the photographs. So microphthalmos and enophthalmos, these occur due to abnormal development of the optic vesicle, and microphthalmos is anatomical size of less than 2 standard deviation for age, and enophthalmos is complete absence of the eyeball at birth. The management, it has to be tackled in the very right way because it provides the cosmesis and thus a huge psychological impact. So serial size conformers are placed, and if there is a volume deficit, expansion is done, and finally surgeries are done to enhance the cosmesis. So aim of our study was to study the epidemiology, management and outcome of such cases. This is a retrospective descriptive study which is done in the Department of Oculoplasty in Little Flower Hospital, Langamali. Duration was 5 years and it was done from January 2013 to January 2018. All such cases of congenital microphthalmos and enophthalmos which entered into the OP were taken into account. So the following details were taken from the case sheets: age of presentation, prenatal infections, maternal complications, presence of any orbital cysts, ocular and systemic abnormalities, treatment modalities, and also we use the pre and the post-treatment photographs. So a conformer which was fitting the aperture was given first, and it was followed up. Once it rotates or falls up, next size serial conformer was given, and serial size conformers were given, and finally the prosthetic eye was given. So how did we measure the outcome? One thing, we looked into the retention of the conformer. Secondly, we measured the horizontal fissure as well as the vertical fissure increase in these both parameters. And finally, we also looked into the parent satisfaction. A parent scale of 10 was noted. So how did we measure the increase in the palpable fissure heights? So here you can see the pre-treatment and the post-treatment photographs. We took the ratio, actually, the fissure size and the abnormal eye to that of the normal eye. This was compared with that of the post-treatment photograph. So here you can see it is A bar B is compared to the C bar D. So the results, 26 eyes of 23 patients were analyzed, and the age of presentation were 8 days to 7 years. Microphthalmos, there were 16 and 10 enophthalmos case. Antenatal complications, there were nil complications in the majority, just 3 cases of pyrexia and 2 cases of GDM. Torch antibody, it was negative for majority of the cases. Only 2 cases we had positive, and it was negative in case of enophthalmos and bilateral cases. Orbital cysts were seen in 3. Systemic abnormalities were seen in 4 cases. Delayed milestones, nasal deformity, subarachnoid hemorrhage at birth, and ocular abnormalities, there were only 2 cases noted with cataract and hyperplastic vitreous and RD and coloboma, and 70% of the cases were managed with conformers alone, as you can see in the photographs. So this was a case of enophthalmos. We had to place, we couldn't even place an conformer proper, so we had to use a mole wax. Surgical interventions, it was done only to enhance the cosmesis. Lid surgeries were performed, levator resection, frontalis link, cantoplasty in 3 cases, fornix forming sutures were done. So here's one case with cantoplasty, another with lateral cantoplasty and frontalis link. So in 2 cases of large cyst, aspiration was done and sclerosing injection was done. On comparison the fissure size, you can see that this is the pre-treatment photograph, pre-treatment data, and there is a huge increase in the size, and both in the horizontal and the vertical size, and the p-value was found to be significant, statistically significant. Again, the same was observed in case comparing the various age groups. So we also obtained good results in the older children. Again, it was done in case of microphthalmos and enophthalmos. Microphthalmos obviously had a better outcome. Satisfactory scale, most of the parents gave us a score of 9, and the average score was 8.6. So a discussion when we compared it with other studies, we had comparatively more number of cases of enophthalmos, lesser number of ocular and systemic abnormalities, and majority of the cases were managed conservatively. And majority of the surgeries done for lid surgeries. And I could only find out only one similar study wherein there was comparison of using the photographs actually. So this was a Japan study, and the post-treatment fissure size, it was comparable. So what I wanted to highlight is, in such cases of retrospective studies, comparing the ratio of the fissure height pre and post-treatment using the pre and post-treatment photographs, this can be used as a method for outcome measurement. So even in the older children, it brings a good result. And microphthalmo outcomes are better than enophthalmos. This is a well-known fact. Limitations of the study was that it lacked orbital volume details, and imaging of the orbit was not done. Hence, bony hyperplasia could not be assessed. So the conclusion is that treat every child, because you can see how lot difference it makes. Thank you.
Well, I have a few questions to ask.
Sure.
One is that how did you compare your vertical height pre-treatment and post-treatment?
Similarly, sir, with a ruler only. But
how can you compare vertical height if nothing is placed in the eye?
So we use the photographs,
No,
pre-treatment and...
See, there is no eye inside, or the very minimal vertical, very minimal eye is there.
Yes, sir.
So unless and until you open the fissure, you will not be able to measure the vertical height. Horizontal, yes, I can understand.
Yes, sir. It was almost minimal only, but then using the photograph, we could measure it was around like 1 millimeter or so, less than that even, in some cases. So whatever was available in the photographs, we had taken some.
All right. The other thing is that you did not mention about the minimalistic surgery, which is done at least in our setup in most cases, that doing a canthotomy, cantholysis and a tarsorrhaphy. So that was not discussed as a treatment surgery in any of your case. Like whatever surgical modalities you discussed were of little this thing more ticklish, but this was not performed in any of the cases?
Not, sir. In those 5 years, we had not done actually. Sure. These were the surgeries that were done. Actually.
Okay.
Yes, sir.
All right. Okay.
Thank you, sir.
Yeah, please.
So, thank you, Dr. Indu. I have nothing to ask. And may I call upon the next speaker, who's going to talk about orbital lymphangiomas, characteristics and treatment outcomes with bleomycin.
Good evening. I am Dr. Donna and Matthew from Little Flower Hospital, Angamali, presenting a paper on orbital lymphangioma, characteristic and treatment outcome with bleomycin. Orbital lymphaticovenous malformations are abnormal vascular channels lined by the endothelial cell with a spectrum of venous and lymphatic characteristics. Orbital lympangioma account for the 25% of the orbital vascular lesion and 4% of all orbital lesions. These are rare and low flow lesions. Clinically, they present with unilateral proptosis, swelling and displacement of globe, limitation of eye movement, and there can be a sudden exacerbation of proptosis due to spontaneous bleed into the lesion known as chocolate cyst. Most of it do not have a radiological connection of vascular lesion. CT angiogram. This here we can see there is an extensive lesions on imaging, which includes extent from the anterior to the posterior orbit, and enhancement can be seen when there is a venous component in the lesions. MR angiogram do help in showing a fluid level, showing an old lesion from a new fresh bleed in the orbit. So treatment options, we know the surgical excision due to the extensive and infiltrative diffusely into the lesions, spreading into the surrounding tissue. Surgical management is difficult and often we end up with just debulking the lesions. So non-surgical intervention, we have sclerosing agent, very well famously used as sodium tetrahydrosulfate, then newer steroids, interlesional steroids, and doxycycline forms. So the aim of this study is to report the patient characteristic and treatment outcomes with bleomycin. So this is a retrospective data analysis of 12 cases at a tertiary eye care center performed during the period of 2019 to August 2022, aged from 6 months to 68 years. So diagnosis is basically on clinical signs and symptoms and radiological and histopathological reports on previously diagnosed cases. Data collected was signs and symptoms and thorough ocular examination, systemic evaluation, imaging, and treatment results were analysis. So bleomycin, we know it is a cytotoxic, anti-tumor, antibiotic. The desired effect of sclerosis is achieved when the bioavailability of the drug per unit surface area of the lesion is good. So action is sclerosing, that is when it is a non-specific inflammatory reaction on the endothelial cell, apoptosis and cytotoxicity due to the inhibition of DNA synthesis. Bleomycin, it comes as a freeze-dried drug, which comes in 15 units, which is reconstituted with 2 ml of 0.09% normal saline and further made into 1 unit per ml concentration. The dosage is 0.5 to 1 units per kg body weight and does not exceed 10 units at a time during the ingestion. Procedure, we have done a blind procedure. So after assessing the CT, we used to identify the site of the lesion. Then we used to go in with a 24-gauge needle, needle attached to a 5cc syringe, and it is inserted into the lesion and the fluid is aspirated. So according to the aspiration of the fluid, the ingestion of the drug is in the ratio of 5:1, and then the needle is left in situ, and corresponding to the amount of the aspirated fluid, the drug is injected into the lesion, following which the eye is padded and the patient is reassessed on the day 1, then 1 week and 1 month and 3 months follow-up is advised. So clinical response was assessed based on the reduction of proptosis, improvement in the EOM, and reduction in size of the lesion. Result, so 7 cases showed a total resolution or after the single injection of bleomycin. 5 patients showed good response but required multiple injection. There were local or systemic side effects or nil to encounter. So long-standing cases showed poor response. So this is a case. This patient had come in 2019. This was his first visit. We can see post bleomycin, there was a considerable improvement. Then later in 2020, again he recurred. And this is what we observe is the proptosis obviously have a much better reduction than the extraocular movement. Then this is a child. This child was diagnosed as a case of orbital lymphangioma from the 6 days of her birth. Then she presented into our OPD during our study period. She is post bleomycin and post surgical debulking. So this is a CT picture, and we tried aspiration and intralesional bleomycin to the patient, and 1 week follow-up, and this is a 4-month follow-up of this child. So this is another case of bleomycin, orbital lymphangioma, diagnosed long back, and the patient recurred saying there is a subluxation of late, and then we tried injection bleomycin therapy, but she didn't show much response. So conclusion is that orbital lymphangioma cause functional structural impairment, but the management obviously is challenging. But bleomycin is a safe therapy, and absence of flow voids helps in safe delivery of the bleomycin. Long-standing cases, the response is poor, and no side effect was noticed during our study period. Thank you.
Dr. Donna, I just had a question. What was the effect on vision? Did you document the vision in all these patients that you did?
Yes, sir. If it is like presenting with the spontaneous chocolates, this kind of an presentation, obviously the patient vision was less.
No, I'm not asking that. I'm asking in your study.
In my study, yes. If we have given a bleomycin, obviously there was an improvement in vision. It's not like...
all your patients had improvement in vision?
Yes. Except for the long-standing patient, which was already a prolonged case. The patient didn't have much, but the children obviously had a very good improvement, like 2 to 3 Snellens improvement, and was there.
Okay, and you encountered any complications in your series?
No, sir.
Nothing at all.
Nothing at all. Maybe a slight amount of lid edema in the next day. Otherwise, nothing.
And did you
Nothing.
have an MRI with contrast and for all these patients to see the flow voids?
Not all the patients, sir. Not all the patient, because MRI for a child, it is difficult. We don't have a GA backup. So wherever possible, we tried MRI. Otherwise, CT angiogram was done.
Okay, and they're all low flow
Yes,
lesions.
yes. That is something which really looked into.
Okay.
I have a question to ask. One, what was the exclusion criteria in your study?
So we didn't have a particular exclusion criteria because we were looking into the orbital lymphangioma and we are trying to see the outcome of a bleomycin patient. We have taken a biopsy proven cases also. We just wanted to see how the bleomycin worked in orbital.
No age limit was there in your
No,
study.
we didn't
But
keep it.
what literature says? What is the age limit beyond which you should not be giving, or less than which you should not be giving?
There isn't a literature quoting on that as far as I know of, sir. I looked into that because even in small ages, they are giving bleomycin, maybe, and even 60. One study I've seen in 68 where bleomycin was done.
See, in less than 6 years and in pregnant women,
Yes, pregnant women is not. It's
in
not
both,
advised.
both these groups, bleomycin should not be given.
Yes.
If you are giving it, then as a special case, you need to take special consent. So that you should always remember. One other thing which you have spoken is that you have given injection after taking, like in 5:1 ratio.
Yeah.
5 ml fluid you aspirated out,
Yeah.
and then 1 ml.
Yes, sir.
That's not the thumb rule. In not all lymphangiomas you get such amount of fluid to aspirate.
Yes.
So in many of the lymphangiomas, it's almost a kind of dry tap.
Yes.
So there also one may need to, and I don't think in all of your cases you could aspirate that much amount of fluid. So I think there
Definitely,
is
sir. It
some-
was like sometimes we just got 3 ml.
So
It
you
we
are-
do varies, but the aspiration rate is always like if it is 5 ml, we use the only 5:1. That is the drug regime we had selected for the cases.
Okay, thank you.
Thank you, sir.
Presentation. So we call upon her to present here. Second last.
A very good afternoon, everyone. Good afternoon, judges, seniors, and my dear friends. I'm grateful for this opportunity and thanks to my mentors for their constant guidance and support. So my topic is transconjunctival intralevator triamcinolone for the upper lid retraction and thyroid eye disease. Thyroid eye disease, as we know, it is an enigma. The most common disease that affects the orbit. It is complex, and yet it is poorly understood autoimmune pathology. It affects, basically, it's an autoimmune mechanism which ultimately affects all the things that are present in the orbit, starting from the fat, the muscles, as we know. And the complications that can happen is lid retraction, myopathy, proptosis, and optic nerve dysfunction. Also, we know that it has a natural course of the disease. There's a dynamic phase, which is the active phase, and the static phase, which is like the inactive phase, which is commonly known as the Rundle's curve. The most common eyelid symptom that we encounter here is eyelid retraction, which is seen in 90% of the cases. What is the mechanism of eyelid retraction? Well, overaction of levator and Muller's muscle, which is because of the increased sympathetic tone or the fixation duress, the levator hypertrophy, levator muscle contracture or fibrosis, abnormal adhesions between levator and surrounding structures, scarring or inflammation of the septum and the anterior lamella. So the challenges that we face are functional, which can cause lag of thalamus or exposure keratopathy, or cosmetic, which can actually be a psychosocial impact for the patients. And the management options that we have in our hands are either surgical or non-surgical. Okay, but the question here arises is what to choose, when to choose, how to go about it, what are the results that we get with these things, and how many injections or the surgeries that are required, and when do we do it, whether in the active phase or the inactive stage. So as we know, surgical treatment can only happen during the inactive stage when the fibrosis has set in, which is unpredictable, it is irreversible, it is invasive, it can lead to under or overcorrection, and definitely it leads to it can lead to inadequate lid contour. The non-surgical options in our hand are botulinum toxin, hyaluronic acid gel fillers, and triamcinolone. So we focused on the role of triamcinolone injection in our study, and we evaluated its role in lid retraction in thyroid eye disease patient. It was a retrospective interventional case series of 37 eyes of 22 patients from January 2019 to August 22. And all the patients underwent the triamcinolone injection in an OPD setup using a Demar's retractor. We evert the lid, and subconjunctivally we give this injection for the upper lid retraction. The analysis is as follows. We had the maximum age group fell between 36 to 45 years, and the mean age was 46.2 years in our patients. Females were more, 13, more than males, and bilateral disease was more, that was 13, seen in 13 of our cases. Maximum of our cases were hypothyroid, otherwise hypothyroid and euthyroid status was also seen. The disease was active in 6 cases and inactive in 16 cases. So the result was the mean number of injections that was required was 1.7 with a range of 1 to 4. Maximum number of injection that was required was between 1 to 2. Mean average dose was 23.7 milligrams, and time to maximal response was a mean of 37.6 weeks. And all the values that we measured pre and post treatment, the MRD1, the PFH, the superior scleral show, and the lag of thalamus showed statistically significant change. At the mean follow-up 16.3 months in our cases, MRD1 showed a reduction of 1.5 millimeters, which was statistically significant in all our cases. And there was no significant regression from the maximal response that was seen. And only one patient on the first follow-up showed a slight increase in intraocular pressure, which settled down by his next follow-up visit. So as we see, the questions that we started with can be answered by this simple injection that we use. That is the intra-LPS triamcinolone injection, which can be used as far as our study goes in active and inactive cases. A total of 1 to 4 injections were used. Long-term effect, it was the disease was stable in more than 6 months. There was no local side effects that we could see, no ocular side effects, and definitely it could be used in both functional as well as cosmetic concerns of the patient. And we had excellent results in all our cases. These are the few of the studies that have been done, and our studies also prove very gratifying results. And the mechanism proposed is anti-inflammatory effect on the molars or the LPS. These are all hypotheses that have been proposed for these injection, or aponeurotic detachment or myopathy causing ptosis. Even thinning of muscle has been described how this injection works. And although the studies say that targeting the inflammation in acute phase when we are ahead of the disease before the fibrosis actually sets in, it gives better result, but we could see the results in inactive disease also in our study. So the conclusion is effective and long-lasting modality is lacking. It is a challenging situation, and injections like triamcinolone, there is ease of administration, it has a short down time, it can be used during the active phase where nothing else can be used, like especially the surgery, and improve quality of life for the patient, and it definitely broadens our arsenal to help these patients. These are my references. Thank you so much.
What is the mean number of injections, like how many injections per case you give?
It ranged from 1 to 4. Maximum 2 injections were required in most of our cases, sir. It was
1 to 4 means maximum
1 injection. Yeah, so when we follow up, like we gave 1 injection and we follow up the patients after 6 to 8 weeks. If the retraction is still present and it is significant, we go ahead with the second injection, and basically we clinically take a decision when to give the next injection. So few studies have actually followed up the patient exactly at 1 month, 3 months, 6 months. We did not follow up exactly at a same interval, but we followed up clinically as and when the patient were required to be followed up. And if it was a cosmetic concern for the patient, we went ahead according to their need of the injection, sir.
So maximum 4 and average 2.
Yes, sir.
Continuing with what Dr. Mukesh was asking, what was the clinical parameter which decided that you need to repeat your injections?
So the superior scleral show. One is definitely, we had 2 categories of patient. Many patients wanted it for the cosmetic reasons also. So the superior scleral show was more than 1 millimeter. We went ahead with the injection. In severe cases, when there was too much of a lag of thalamus and the palpebral fissure height was so large that we had to give when the IVMP was going on. These injections were actually given when the IVMP cycles were going on for the patients. It was just for the local relief of the scleral show, sir. So that was the criteria that we kept.
Right. Thank you, Dr. Shaifali. Actually, nice presentation and nice concept now, which is coming on to treat lid retractions, especially in patients with thyroid orbital
Yes, sir.
disease,
Yes, sir.
because that is one component which is very difficult to treat.
Yes,
And
sir.
surgery was the only other option. So, do you know how it works? Can you just enlighten us?
So, sir, the hypothesis, as we say, like one is the depot of the drug that is there in the lid. It actually causes a kind of like a ptosis. One hypothesis is that. Second is the anti-inflammatory effect of the injection that has been proposed, because it's ultimately an autoimmune inflammatory disease. So we are actually acting on the inflammation that is going on in the lid. So 2-3 hypotheses, sir.
Right. Actually, the reason is very simple. We all know that chronic use of steroids intraocularly can cause ptosis.
Yes, sir.
So using that particular effect
Yes.
to cause ptosis, right?
Yes.
But instead of putting it in the eye drops, because that can cause glaucoma and other problems, you have another route where you put it where you want it, and you hope that the same effects which cause ptosis kick in.
Yes.
Right? That's the reason why you need to give multiple doses in most of the patients.
Correct.
Right? So this causes stretching of the entire LPS complex, and that's how you get a ptosis.
Yes.
Thank you.
Thank you,
very
sir.
much.
All right, marking you.
Distribution of males and females in our study. Age-wise also, it was comparable in each age group. We had 4 age groups, 0 to 20, 21 to 40, 41 to 60, and more than 60 years. So this is what we see on UBM of the eyelid. This first hyper-reflective, hyper-echoic layer which we are seeing is a cellophane sheet. This bilaminar structure is the anterior and posterior surface of the cornea, angle of the anterior chamber, iris, and whatever is there in between is the eyelid. So just to orient you guys, this is the superior, like towards the superior orbital rim. This is towards the eyelid margin. So the first hyperechoic structure which you are seeing is the skin and subcutaneous tissue. Then throughout the length of the eyelid, there is a hypoechoic structure which is orbicularis oculi. Then tarsal plate was also visualized as a hypoechoic structure, and there were some hyperechoic densities inside the tarsus which can be presumed to be the meibomian glands. And then there was a hyperechoic structure coming from the above and attaching on the anterior surface of the tarsal plate, which can be the levator aponeurosis. It was difficult to distinguish the levator muscle, the muller muscle, and the conjunctival separately. So we just clubbed it together and named it as levator muller orbital septal conjunctival complex, LMSC complex. So, in our study, the mean eyelid thickness was found to be 1.66 mm. Tarsal thickness was 0.73 mm. This also correlates with the histopathological thickness which has been described in the literature as like 1.5 to 2 mm has been described for the eyelid thickness and around 1 mm for the tarsal thickness. Then orbicularis thickness was 0.31 mm and LMSC complex thickness was 0.63 mm. Now, on comparing the thickness between males and females, there was all the 4 parameters which were measured were slightly more in males as compared to the females, but this difference was not statistically significant. Then in comparing between different age groups, the eyelid thickness overall was found to be thicker in older age group as compared to the younger age group, and it was significant. And along with this, the orbicularis was also found to be thicker in the older age groups. So this increased thickness of orbicularis can be the thing which is contributing to the increased eyelid thickness in the older age groups, and it can be presumed to be due to fibrofatty infiltration, like degenerative changes in the eyelids in old age group. However, further histopath studies are required to confirm this. So, knowledge of anatomy of the eyelid is very important to have a good surgical outcome in any eyelid surgery, and we can use UBM as a non-invasive and cost-effective measure to visualize the eyelid structures pre-operatively. Previously, also studies have been done to visualize the various eyelid lesions, and the size and the characteristic of the lesion of the UBM has correlated well with the histopath characteristic, but very few studies have described the normal eyelid anatomy. So hence this study was conducted. So I would like to conclude that our study showed that normal eyelid structures can be visualized accurately on ultrasound biomicroscopy, and it can be used as a non-invasive, quick and cheap alternative for eyelid imaging, and it has a potential use in planning various eyelid surgeries also. Thank you.
Thank you, Dr. Jasleen. It's a good study, but of course it doesn't qualify for the competition. Thank you very much. I'd like to call Dr. Anisha Sarkar. Dr. Anisha is going to talk about posterior approach for surgical correction of ptosis, novel techniques for better cosmesis.
Good evening, one and all. This picture shows how traumatizing scars can be. Post-surgical scars are a concern for not only the patients but for the surgeons as well, especially when it comes to oculofacial surgeries. I shall be talking about the posterior approach ptosis surgeries and their outcomes. No financial disclosure. To begin with, the popularly practiced fascicular servage surgery, where the molars muscle, conjunctival and tarsus are resected to gain eyelid elevation. Next comes the novel techniques, the molars muscle conjunctival resection, where only the molars muscle and the conjunctiva resected and the tarsus is not touched. And the last is the posterior approach, white line advancement. The objectives of our study are to determine whether the posterior approach ptosis surgery gives comparable functional outcome and better cosmetic outcome to that of anterior approach levator resection. It's a retrospective cross-sectional study where we have chosen 47 eyes with ptosis in 32 patients, 24 eyes with mild ptosis and 23 eyes with moderate to severe ptosis. We have excluded patients with poor levator function with other pre-existing eyelid pathologies and patients with cranial nerve dysfunction and other associated abnormalities. A quick glance at the study performer. So all the patients underwent meticulous ptosis evaluation of other clinical parameters like the brow fat span, the tarsal platform show the lid contour. all patients colored digital photographs were taken for all the patients, and the patients were divided into two groups, group A and group B. All patients group A underwent anterior approach levator resection. Mild cases of group B underwent MMCR, and moderate to severe cases white line advancement. Patients were all evaluated at the immediate post-op day, month 1, 3 and 6. The results were all statistically analyzed. Coming to the results of our study, we have observed a comparable eyelid elevation in both the groups, and the p-value is statistically insignificant. Also, coming to the inter-eyelid asymmetry, the inter-eyelid height difference is comparable in both the groups, that is the anterior approach and the posterior approach group. Again, the p-value is statistically insignificant. Coming to the cosmetic outcomes, the tarsal platform show, the symmetry of the tarsal platforms show is considerably better in the group B patients compared to the group A patients, with a statistically significant p-value in both mild and moderate to severe cases. Also, the eyebrow fat span is significantly symmetrical in cases of the posterior approach ptosis surgery, again with a significant p-value. Here are the pictures are the instances of pre and post intervention in cases of LPASA, white line advancement and MMCR, and we can observe a significant better symmetry in terms of tarsal platform show and the eyebrow fat span in cases of white line advancement and MMCR surgery. Coming to the lead contour, this is an observation, this is a subjective observation, and for the purpose of our study we have graded it into good, fair and poor, and we have observed a considerably good eyelid contour in cases which underwent posterior approach ptosis surgery. Coming to the discussion of our study, we, as said in the literature and as also observed from our study, eyelid symmetry plays a very significant role in the overall facial appearance, and so to achieve optimum cosmetic result, not only the eyelid height but the eyelid contour, eyelid crease and the eyebrow position should be taken into account. We have observed a significantly better eyelid contour score in cases of posterior approach ptosis surgery, and this is probably explained by the fact that the septum is not incised in these cases and the tarsus is minimally handled. Coming to the eyelid crease and the eyebrow height, this is based on the understanding of the fact that the eyelid is a three-dimensional structure, and the eyelid appearance is determined not only by the lid crease but by the tissues that fill the eyelid space, and this is achieved by relaxation of the eyebrow compensation, which allows the eyebrow to descend down and to recruit more tissues into the eyelid space. So the overall advantages of the posterior approach ptosis surgery is better outcome in terms of tarsal platform show, the brow fat span. There is also no significant post-operative scarring and significantly low post-operative recovery period. So to conclude, meticulous pre-operative assessment, good patient selection, proper patient counseling, realistic expectations of the patients are key to a successful ptosis surgery. Also, documentation with digital colored photographs are extremely important, and to get overall symmetric facial appearance, we should consider parameters like the tarsal platform show, the brow fat span and lid contour. Wherever applicable and there is no contraindication, posterior approach ptosis surgery gives a overall better lid contour compared to the anterior approach and with a less post-operative recovery period. These are my references. Thank you.
Good work, but I've got two questions to ask.
Yes, sir.
One is that you have said there is a better tarsal platform show in posterior approach, let's say.
Yes, sir.
So can you elaborate on that? Because tarsal platform show would be there when there would be symmetrical anterior lamina and posterior lamina of lid.
Yes.
Whenever we are doing posterior approach lid surgery, the major disadvantage is that you are not able to tackle the anterior lamina, meaning by you are not being able to cut the skin muscle
Yes.
in posterior approach. Whenever we are doing surgeries on severe ptosis and we are doing more of work on the levator, more work on posterior lamina, anterior lamina is bound to be excessive and there is overhanging of fold.
Yes.
So it goes opposite of your inference that tarsal platform show was better in posterior approach lid surgery. That's contrary to the general belief.
So this is probably explained by the fact that the septum is not incised. So the overall stability of the eyelid, which is mostly because of the intactness of the septum and the tarsus. Also in the posterior approach ptosis surgery, the tarsus is very minimally handled. So that probably gives a better symmetry and that confers to overall better facial symmetry.
All right. And the other question was that in bilateral cases also, like you have taken bilateral ptosis in those patients also where ptosis
Yes,
was
sir.
severe. You have
Yes.
included those patients
Yes,
also.
sir. Yes.
So, is that a choice surgery or you would like to do sling also in those cases?
No, sir, we
Why?
did not do sling in any of the cases. In all the severe ptosis, we either did anterior approach levator resection or a posterior approach white line advancement. We
In
did no sling.
bilateral cases.
Yes, yes.
I have a question, Dr. Anisha.
Yes, sir.
Along with the ptosis or MMCR surgeries that was done, that is the white line advancement, was any blepharoplasty also done simultaneously?
No, sir, we have excluded the cases where we have done a combined surgery for this study. We have excluded those cases where we have done the combined bleph as well, because that itself adds to the eyelid improvement of the eyelid contour and the facial symmetry. So we have excluded those cases.
It's fine if you've excluded, but actually when you have large severe ptosis, and especially in adults, there'll also be an anterior lamellar loosening.
Yes, sir.
So once you
Yes,
tighten
sir.
the posterior lamella, you will also have to address the anterior lamella subsequently.
Yes, sir.
So that's how you do a blepharoplasty, and you can.
Yes, sir.
combine
We
that
have
with the
done
posterior
bleph
lamellar
for
procedure.
those cases, many
So for
cases like that, but we
for
have
the study, you not
excluded.
include them. That's
Yes,
what you
sir.
mean to say.
Yes,
That's
sir.
fine. Okay.
So our next presenter is
Those cases, many
So for
cases like that, but we
for
have
the study, you not
excluded.
include them. That's
Yes,
what you
sir.
mean to say.
Yes,
That's
sir.
fine. Okay.
so our next presenter is
Thank you, sir. Good evening, everyone. I'm going to present laces flare and easy technique with great fine result. In the era of advanced technology and techniques in the medical science, I would like to throw some lights on the basic technique, which does not deal with the advanced mechanics, but its result and approach was very useful in our day-to-day practice. As we face in our clinic these type of the cases, and also these are the cases, this is very difficult to manage for the everyone. These cases are managed by the simple laces flare technique. It was first described in 1957 by healing by secondary intention, has been time-honored method for the management of plastic surgery. Because it is dampened because of fear of suboptimal cosmesis and functional outcome. In our study, it was to examine the role of secondary intention in the healing following the excision of lower lid tumor in cases that would have normally required extensive flap or skin graft to close the defect. The aim of our study was to see the function and cosmetic outcome. It was done on 41 patients, the case series, and the data was collected prospectively and analyzed. It is done at AIOC2023 Patna, 2018 to 2020, and follow-up was done at day 7, 2 weeks, 1 month, 6 months. And at every follow-up, size of defect, time taken during the surgery, comfort during healing, functional, cosmetic outcome, and recurrence was noted, and data was analyzed at the end of 6 months. Informed and written consent were taken regarding the outcome of the disease from the patient and attendant, and proper explanation regarding the surgical procedure was done. No financial interest to exclusion criteria was tumor involving more than 2/3 of the lower lid, including lid margin. Incisional biopsy confirmed in the large cases by malignant cases was taken. Clinically and radiologically localized tumors included in the study, and size of the defect was length of 14 to 23 millimeter was included. Exclusion criteria, patient was not given the consent, and any comorbidity was excluded from the study. The surgical procedure was done after the proper and local and systemic evaluation under aseptic and antiseptic precaution. Excision of the tumor was performed under local anesthesia by the same surgeon. Lesion were excised making 4 millimeter away from the clinically visible extent of the tumor and left it to granulate. All the excised tissue was labeled and sent for the HP confirmation for diagnosis and to assess the tumor clearance margin. After the maintaining the hemostasis, pad and bandage was applied. These are the follow-up patient for doing surgery, and at the end of 1 month, the safe wound was healed properly. And also, this cases was managed with this technique. These cases were having the HIV positive, and it was managed nicely. And these are the follow-up patient of the same technique. And data was in the result. A good function and cosmesis was obtained in the 39% of the 41%. Most of the patient was ranges from age was 45 to 75 year. More male was more in 29 and 12 was female. Wound area involvement or length is 21.25 plus minus 3.9 millimeter. Involvement of the lead was lateral canthal was involved in 6%, medial canthal was 3%, and involvement of both canthal were 5%, and no canthal involvement was 27%. All tumor free margin was noted on HPE. On HPE, there was sebaceous cell carcinoma was found to be 24%, followed by squamous cell carcinoma and basal cell carcinoma. Post-op complications were noted. 2% had the psychiatric ectropion, 1% granuloma formation, 4% complaint of watering, and foreign body sensation was noted in 2%. Post-operative satisfaction questionnaire was made, and 91% was satisfied with their results and outcome. 1% noted at the end of 2 months of recurrence. This patient was managed the basal cell carcinoma, but patient noted at the age of 2 months there is something wrong with the lead margin, and again patient was managed with the same techniques, and patient is happy with the at the end of 6 months. So on the discussion, a small periocular skin defect can be closed easily by direct closure by aided by the lax and reburdant tissue. However, the larger defect may require reconstruction with the combination with skin mobilization, skin flap, pre-full thickness skin graft. These techniques are not without the cosmetic functional limitation. Allowing the wound to heal by second intention is a viable alternative. In our case series, we obtain a good function and cosmetic result in 39% of the 41%, that is the 95%. Although the literature was less available, but all the authors are also in favor that they have noticed these techniques are the good alternatives. In our study, at the end of 6 months, 91% patients were satisfied with the term of function and cosmesis. So conclude that healing by secondary intention as a laser flare technique is an effective, safe and simple alternative. Larger wound gap can be reconstructed easily after a few days. Recurrence of tumor can be easily recognized. This is useful where the project success is not available. So long-term follow-up is required. Thank you so much, sir.
Thank you. I had a couple of questions, Dr. Bhaskar. One is, how did you manage to get a consent form that you're not going to reconstruct? That's very difficult. How did you even convince your patients? On a lighter note, of course. Sir,
because some center have no frozen section control. When we large tumor, we are dealing with a large tumor. If without frozen section control, still we have to wait 10 to 12 days for reports come. Histopathology reports will come. most of the cases in our center, initially there was no frozen section. So we have to wait at least 7 to 10 days. Mostly some reports came after the 12 days. Most of the wound was healed in the meantime. So we decided that when some of the patient were satisfied, not wanted to re-surgery. So we decided that most of the patient is older one, and most of the tumor is in the lower lid. So it is cosmetically it is not, and functionally because it is not exposure. So we decided to do the same thing,
I
sir.
have another question, Dr. Gyan Bhaskar. This was a study conducted, or is just your observational study that you presenting here? Was a
Sir,
proper study, is it?
initially, sir, it was the observational, but we did the study later on, sir.
So did it clear your scientific and ethics?
Yes, sir. Yes, sir. We have taken the scientific ethical clearance
And
from
how
our
did
institute.
you manage your infections? What was the protocol to prevent infections? Because just leaving a wound open.
Sir, a small because it's a lower lid, and only we have to pad and bandage for 2 to 3 days. Then patient after hemostasis, patient only dressing of the betadine, sir, and local application of the ointment, antibiotic ointment, and oral antibiotic 7 days, sir.
Okay.
All right, good study, but as it's been pointed out, it's very difficult to get consent from the patient also and convince yourself also to leave patient in such open condition. Generally, for difficult medial canthal problems, this particular technique is reserved. Like there are people who do it for difficult medial canthal reason, but for all and very large lower lid defect, it's really it requires a lot of courage, basically. All
Sure.
right, thank you.
Thank you, sir.
May I next call upon Dr. Orbital cerebral mucormycosis?
Thank you so much, respected chair, and good evening, everyone. I'm going to present my study on ocular blood flow in patients of mucormycosis. Mucormycosis, we all know, is an angioinvasive fungal infection with high mortality and morbidity, and that has been increasingly reported in patients of diabetes mellitus, malignancies, organ transplants, and corticosteroid therapy. Especially during trailing end of second wave, we saw a dramatic surge in the number of the cases, and it leads to tissue infarction and necrosis of retroorbital space and subsequent orbital apex syndrome, leading to various ophthalmic manifestations like total ophthalmoplegia, proptosis, and loss of vision. When we searched the literature, what we found that there was no documented study to document the ocular blood flow and occlusive pathophysiology of the disease, and there was no correlation of inflammatory blood markers with ocular blood flow. So with the aims, we did this study to compare the ocular blood flow parameters in the patients of ROCM in both involved and uninvolved eye, and also to correlate these parameters with inflammatory markers of the patients, so as to gain insight into the disease pathophysiology. This was a hospital-based cross-sectional study where 91 cases of mucormycosis were checked, admitted in GSVM Medical College, Kanpur. Out of which 17 cases of biopsy confirmed mucormycosis, in which one eye was involved and the other was not involved, were included. This was approved by Institutional Review Board and informed consent was taken. Now, detailed history and examination was done for all the patients with regards to best corrected visual acuity, IOP, ocular movements, and so on and so forth. And diagnosis was confirmed by KOH mount and biopsy taken from the middle turbinate of the patients, which was sent to microbiological lab of the institution. This was the sonocyte machine on which color Doppler flow was checked for these patients. Now we can see it was primarily done for 3 arteries: short posterior ciliary artery, ophthalmic artery, and central retinal artery. We can see the graph. The trough of the graph is the diastolic velocity and the peak is the peak systolic velocity, and resistivity index is automatically calculated by the machine. Here we can see the reduced peak systolic velocity and diastolic velocity, and in this photograph we can see that there was no blood flow, and we can see a small emboli occluding the central retinal artery. So in results, out of 17 patients, majority were male. 8 patients were PL negative at the time of presentation in the affected eye. The best corrected visual acuity in rest of the eye was 1.3 plus minus 1.3 logMAR unit. Best corrected visual in uninvolved eye was 6/6. Now this is the involvement of the muscle. If one muscle was involved, the number was given as 1, and for 2 it was given as 2, and for 3, and for 4 muscles it was given as 4. If all the muscles were involved, the number was given as 5. Majority of patients, they had 2 muscles involvement, 35%, and here we can see 3 muscles were involved in 29% of the patients. All the patients were post-COVID and all the patients were diabetic, and they out of these 60%, almost 60% patient, they had history of steroid usage. Now the mean age was 50 years of age. IOP in the affected eye was slightly higher than unaffected eye, but the p-value was not significant. Now this is a slightly busy slide which is showing the various ocular blood flow parameters in central retinal artery and short posterior ciliary artery and ophthalmic artery. We can see very clearly that peak systolic velocity in affected eye was much lesser, around 4.13 millimeter per second square in comparison to unaffected eye. Similarly, when we see the end diastolic velocity, it was significantly less than unaffected eyes, and p-value in all the arteries were significant. So this is the same graphical representation. The mean of ferritin level, inflammatory markers were also checked. So mean of ferritin level was 710. Hemoglobin was lesser, 9.69, and TLC was 9,500 in our patients. MCV being also near normal, 70. Only the ferritin levels were very, very high. When we tried to correlate with the ferritin levels, it was seen that it correlated with peak systolic velocity and end diastolic velocity of central retinal artery and short posterior ciliary artery, not with ophthalmic artery, and there was a negative correlation with hemoglobin values. So because this mucor has affinity for the arteries and it grows along the internal elastic lamina, and they cause thrombosis and infarction. So mean reduction in ocular blood flow parameters confirmed that there was vaso-occlusive disease. Increased ferritin concentration indicates an increased baseline storage of iron in such patient, and that has been seen in other studies also. Now, because there was a positive correlation with the ferritin levels and negative with hemoglobin, that again indicated that there was invasive fungal invasive infection in retroorbital space. The limitation of the study was small sample size, and other inflammatory markers were not estimated. So to conclude, I would say that vaso-occlusive pathophysiology was documented by measurements of ocular blood flow parameter, and increased ferritin levels indicate more invasive nature of the disease. Thank you so much for your kind attention.
Thank you, Dr. Mohan Shalini. Just a question. You measured the OBF. Now, did it change your management depending on the blood flow?
So, in the patients in which the vision was not there, we simply gave them an injection amphotericin retrobulbar. And in the patients...
No, madam, my question is very simple. Depending on your study that you've done, I'm not looking at other factors. Did it help you in determining which patient will require treatment?
Yes, in the patients in whom ocular blood flow was less, they were treated more aggressively because it reduced ocular blood flow was suggestive that they might land up in more problems. So they were treated more aggressively.
Thank you.
Thank you.
Dr. Meenakshi Chinnara.
A very good afternoon to everyone. My name is Dr. Minakshi and I will be talking on the topic surgical outcome and factors influencing monocanalicular tear repair using a mini Monoca stent. As we all know, lacrimal drainage system, it forms the tear conduit channel which opens with a punctum and it ends in the inferior meters. And the canalicular laceration, these are the most common form of trauma to the lacrimal drainage system, constituting 16% of the eyelid trauma and 20% of the globe injuries. And the canaliculi is not supported by connective tissue at its medial end, so it is more prone to injury. So injury may be in direct form or indirect form. And the present day concept is to repair all type of canalicular laceration because the physiologic restoration of tear flow is better when both the canaliculi function well. So stent is also placed for better functional and anatomical role as it improves the epiphora. And in all our cases, we have used mini Monoca stent, which is a silicone rod coated with polyvinyl pyrrolidone of length 40 mm, diameter 0.64 mm. It has a collarate of diameter 2 mm, which makes it self-retaining. So in this picture, we have described that the mini Monoca has been trimmed to up to 30 to 31 mm and its distal end was made beveled for better entry. We conducted a prospective interventional study with 32 number of cases for a duration of 18 months, and we included all monocanalicular laceration patients irrespective of their age, gender, comorbidities and time of presentation, whereas we excluded the patients with bicanalicular tear, the patients who had previous history of epiphora prior to trauma, those who were for secondary repair, any infected cases, and pregnant and lactating women. Data was collected under the heading of age, gender, address, mode of injury, the canaliculi involved, and the duration of injury. So based on duration, the patient were categorized into early and delayed group. Early means injury to surgery time is less than 48 hours and delayed means it's more than equals to 48 hours. Other ocular and non-ocular injuries were also noted, and slit lamp evaluation, intraocular pressure, fundus evaluation, everything was done. CT scan was done whenever required, and the most important was the distance of the lateral lacerated end from the punctum was measured, and based on that the patient were categorized into proximal and distal canalicular laceration. Proximal means the distance between punctum and the lateral lacerated end was less than 6 mm, and distal means it's more than equals to 6 mm. The patients were treated and they were followed on day 1, 1 week, 1 month, 2 months and 3 months. Stent was removed after 8 weeks, followed by which syringing and FDDT test was done to confirm the anatomic and functional success. So these are some photos. The first photo show how we measured the distance from punctum of the proximal lacerated end. The second photo, it shows a Sizzlet refine which was used in 2 of our delayed cases. The third photo shows how we are inserting the mini Monoca, and the last photo, it's a post of day 1 photo of upper canalicular laceration being repaired with mini Monoca. We took 32 patients, majority being male, and mean age was 23.46, with majority of patients between 0 to 14 years, and RTA was the most common mode of injury, and we also had a typical blouse hook injury in 4 cases and a dog bite case. Lower canaliculi was involved in most cases, early presentation was seen in most cases, proximal canalicular laceration was seen in most cases, and general anesthesia was used to repair children, which were 12 in number. Premature stent extrusion was seen in 10 number of patients. Post-op canalicular block was seen in 1. Anatomic and functional success were 96.29%, and we found no significant difference between the early and delayed group and proximal and distal canalicular laceration. So this is post-op day 1 picture where we can see a tube is partly extruded. So in our study, we found a mean age of 23.46 and majority were between 0 to 14 years, which was similar to the studies by Nayak et al. And most common mode was RTA, and also Poddar et al. Found the same result. And in our study, we found early presentation in most cases, but the most common cause of delayed presentation was late presentation, which whereas Chu-Weissi et al. Found traumatic brain injury as the most common cause of delayed presentation. And they also found no significant difference in success rate between two groups. And in our study, we found majority were of proximal canalicular laceration group, but Singh et al. They found distal canalicular laceration in majority, and they found distal canalicular laceration showed better complete success, but we found no significant difference in success rate. Anatomic and functional success was 96.29%, which was consistent with the findings of Poddar et al. And we found stent extrusion in majority of cases, which was consistent with study of Singh et al. And Singh et al. So concluding my study, Mini Monoka has high anatomic and functional success, and it provides excellent results in patients presenting late also. So it's worth being a trial of surgery in all such cases. And the outcome of proximal and distal canalicular laceration repair was comparable with no significant difference. So these are the ethical and scientific committee permissions. Thank you.
I have a question to ask.
Yes, sir.
One is that in your late cases or delayed cases, what was the mean duration of repair? Like when did you repair? What was that mean period?
So the mean was around 11 days, sir, because we also found a patient who came at 20 days late time, sir.
All right, but you did not include more than 1 month or something like that. There has to be some criteria for that, no?
No, sir. Actually, we in that time we have taken beyond 1 month. We won't take the cases, and we included all patients till 1 month.
And how could you do your Sisler? How could you use your Sisler Strepine in those cases?
Sir, since they were delayed patient, so there was a chance of fibrosis, and Sisler Strepine was used, and this cannula, the Trifine was used to make a opening, sir.
Opening where? In proximal cut end or distal
So
cut end?
in distal, basically in distal part, there was more fibrosis chances.
So how could you pass your Sisler Strepine?
So first of all, we detected the calamary sign. Then, whenever it was not possible to find out the calamary sign, we used povidone iodine or tryptophan blue dye in the opposite through the opposite canalicula. It was injected, and pressure over the lacrimal sac was given, so that the fluid or the tryptophan blue dye, it came out through the distal cut end, and by that way we located
there are
the stent.
already adhesions present, then how will the dye come out?
Sir,
You are saying, see, it is not,
yes, sir, yes.
for me, it is not practically possible to pass Sisler Strepine through the blocked distal cut end.
Yes, sir.
It's not physically possible, but you have mentioned it, that's why I am
So
asking.
it was a
because
bit difficult, but not
either you
completely.
no, but if you are not identifying the cut end, how will you be able to? All right.
Okay, sir.
I have a question, Dr. Meenakshi.
Yes, sir.
So can you just tell me what were the factors that influenced the monocanacular intubation? Because you told your outcome, but I think I missed the factors.
Okay, so the first one is the duration of injury, because more delayed the injury is, it's difficult. The functional success rate is very difficult, and the mode of injury also, it is a factor which affects the canalicular tear repair success rate, and the distal and proximal canalicular laceration, the distance from punctum. So studies have said that more distal the canalicular laceration, like Chu-Weissi et al.
No, we'll not look at other studies. You concentrate on what your study
Okay,
is.
sir. So my study found no difference in the success rate between the proximal and distal group.
And which injury you found that it was the worst? You said
Sir,
the injury was...
RT cases, sir.
Okay, fine. Well, I think I missed the slide if you put it.
Okay, sir.
Thank you.
Thank you, sir.
Now we call upon, is also here, Dr. Kirthi Reddy. You are there?
Good evening, everyone. I am representing on transcutaneous retrobulbar amputation B in post-COVID-19 ROCM. So, ROCM has been a relatively rare disease, and it reached epidemic proportion in India during the second wave of COVID-19 pandemic, and a deluge of cases were reported. So the dilemma arises when there is involvement of orbit and the removal of the eye, that is exenteration. They cause significant psychosocial problems, and there has to be a close balance when we are preserving the eye and preventing further intracranial spread. So the delay may sometimes lead to fatal outcomes. So the desperate times needed desperate measures, and we resorted to transcutaneous retrobulbar amphotericin B. So the case series, there have been isolated case series and case reports which have highlighted the use of tram, but there was no consensus regarding its use in invasive ROCM. So this was in pre-COVID era. So the aim was to assess the effect of tram on clinical course of ROCM in terms of alleviating the need for exenteration, post-retrobulbar BCVA, proptosis, extraocular movements, ptosis, and intracranial spread or worsening of the disease, and complications post-tram. So it was a prospective interventional study undertaken at a dedicated tertiary care COVID-19 facility ranging from 29th of May to 31st of July. The previous studies have taken only limited orbital diseases, but when we had our inclusion criteria, we included all the patients with stage 3 ROCM, and patients awaiting exenterations in cases of extensive orbital involvement were also included. The patients with extensive intracranial involvement were excluded, and obviously the patient who did not consent were excluded. So the following variables were studied, and the failure of the tram was defined as worsening of the disease staging or intracranial spread. So the patient admitted were given transcutaneous liposomal amphotericin B alternate day till the patient underwent a debulking surgery, endoscopic or open, and it was resumed from second post-op day alternatively till patient showed clinical stabilization or improvement, whichever was earlier. So the quadrant was chosen and guided by the clinical findings and the radiological findings. This is a video showing the how we proceeded to give the tram. So 45 eyes of 41 patients were included in the study, and this was the stage-wise distribution of the patients. Majority of the patients were in stage 3 ROCM. The median number of injection given was 6, and the minimum and the maximum number of injection were 3 and 8 respectively. Approximately 65% of the patient had improvement in proptosis, 59% had improvement in ptosis, 15% showed a minimal improvement in extraocular movements, but none of the patient had complete recovery. 17 patient presented with PL negative eye, and only 6 showed improvement in BCVA. So this is a minimal improvement in ptosis, and this patient shows improvement in extraocular movements. So 4 eyes ultimately underwent exenteration, and out of these 4, 3 had presented with ophthalmic artery occlusion, and despite repeated tram, they underwent exenteration. 1 patient developed a stage 3 post debulking surgery. None of the patient had extension, intracranial extension or worsening of the disease process, and 5% of the patient had transient post-tram complications like chemosis and slight redness. Previous literature have already supported the use of tram in limited orbital diseases in ROCM. All the 9 patients with limited orbital disease, which were stage 3 and 3B, had a good improvement in all the clinical parameters. They also needed less number of injections. So this was a This was a pre-COVID paper which had supported retrobulbar amphotericin B. These were some of the papers which supported the use in post-COVID-19 ROCM. Patient with not so limited diseases none of them had complete recovery in proptosis, ptosis, and extraocular movements. 25% of the patient having ophthalmic artery occlusion, they underwent orbital exenteration, probably due to orbital infarction syndrome. 6 patients had improvement in vision. Resolution of proptosis, ptosis, and extraocular movements were not complete, but the need for exenteration was alleviated in at least 75% of the blind eye, resulting in an anatomically preserved eye. So the tram basically helped us buy time in cases needing exenteration, and sudden surge in ROCM cases had led to long waiting list of patients needing surgical interventions. None of the patients undergoing tram injection had intracranial extensions. So to conclude, early intervention with tram does have subjective and objective improvement. Its judicious use can help us bring down the morbidity in these cases and also reduces the need for exenteration and help us buy time. So there has been a selection bias in these patients, and the staging was which was followed was a comparatively recent proposed classification. Thank you.
Thank you. How many cases were there in your study? I missed out.
Sir, 45 patients and 41 patients with 45 eyes.
Thank you. One, Dr. Kirti Reddy is not there, right? Right. I think we'll just close the session with this. Thank you. Thank you all speakers. Whoever's here.
Thank you. Thank you all the speakers for presenting such wonderful and nice papers. Thank you.